Acne and acne-related disorders, disorders of sebaceous glands and rosacea. Definition: it is a chronic inflammatory disorder of the pilosebaceous apparatus of certain body areas such as face, torso, and rarely the buttocks, resulting in greasiness and polymorphic skin eruption. Incidence: acne affects all skin types, the male and female ratio is virtually the same but tends to be more severe in males. 85% affects the age group 12 to 24 years, 8% affects the age group 25 to 34 years, 3% affects the age group 35 to 44 years. Etiology: genetic aspect, acne runs in family. Other example, the case of severe acne that is associated with XXY syndrome. Occupation: environmental, mechanical, for example, exposure to acnogenic mineral oil, pomade, acne, dioxin. Drugs: oral and topical hydrocortisone, steroid, acne, lithium, hydantoin, contraceptives. Some endocrine factors are also involved. Pathogenesis: 3 main steps recognized and hypothesized. Deficiency in linoleic acid, the effect of 5-A reductase enzyme on converting androgen, testosterone, hormone 2, the active acnogenic and potent, DHT, the direct effect of IL-1. Here you can observe parafollicular hyperkeratosis. Seborrhea is a common feature between patients with acne. Abnormal production of abnormal sebum, increasing the ratio of wax ester to cholesterol and cholesterol ester, and is believed to be the response of sebaceous glands to DHEA. Colonization of the affected unit with bacteria Propionibacterium acne and yeast, named Malassezia furfur. P. acne is a potent activator of complement via classical pathway. Hydrolytic enzymes released from the activated complement antibodies complex together with exoenzymes produced from P. acne cause rupture of follicular wall. Once the wall is damaged, various agents, prostaglandin-like substance, amino acid, short-chain fatty acids that are produced by the inflammatory cells and P. acne extrude to the dermis, causing more inflammation. Clinical features: acne and acne-related disorders, acne vulgaris, papules less than half a centimeter, comedones, open blackheads or closed whiteheads. Here you can see open comedones, that is blackhead. Here you can see closed comedones, that is whiteheads. In this images you can observe an infected hair follicles which results into inflammatory papules. Acne can also be represented as pustule. Nodules may appear as generalized size of more than 0.5 centimeter. Cystic acne. The cysts are usually large 1-4 centimeters. The nodules and cysts could be associated with sinuses as in acne inversa. Acne inversae, hidradenitis suppurativa, a misleading name, because it is considered by some to be a disorder of apocrine gland, sweat gland, but in my opinion acne inversa. Neonatal acne and infantile acne. Neonatal acne, cause unknown but some believed is due to passing of transplacental androgen. Others suggest the role of Malassezia furfur and Sympodilus. Affect 1 in 5, mainly inflammatory comedones on nose and cheeks. Infantile acne affect males more than females, usually between 3 and 6 months of age, and tend to be severer than the neonatal one and believed to be due to endogenic androgen from the infant's gonads. Acne fulminans affect youngsters 13 to 17 years of age, very severe with ulceration and pus discharge. Associated symptoms include fever, malaise, myalgia, arthritis, and bone pain. Laboratory investigation shows ESR can be induced by starting the PA. Acne conglobata, very severe acne, nodulocystic form with abscess formation, affect torso more than the face, usually associated with Zai syndrome. Acne ageminata, lupus miliaris disseminatus fauciae, some believe it is form of rosacea, granulomatous type. Diagnosis is made at histological base, cast-seeding granulomata at the dermal level. Here you can observe cast-seeding granulomata at the dermal level. Acne as part of other syndromes: Marsh syndrome, melasma, acne, rosacea, seborrheic eczema, and hirsutism. Acne conglobata, Favre-Racouchat syndrome, elderly with illustosis as part of helioderma, sun exposure is a predisposing factor. Polycystic ovaria, occupational and environmental acne. Chloracne. Rare forms of acne affect patients exposed to halogenated hydrocarbons or who ingested chlorinated phenols, dioxin, pomade acne or known as oil folliculitis, acne estivalis or so-called Majorca acne. Occupational. 2. Mechanical acne. Folliculitis nucae or so-called acne keloidalis, pseudofolliculitis barbae, acne excori as part of psychodermatosis. Treatment. Note, all medications used for the treatment of acne act as anticomedonal, anti-inflammatory, antimicrobial, topical keratolytic, retinoic acid 0.025, 0.05, 0.1%, adapalene, differin 0.1%, salicylic acid, benzoyl peroxide, peeling agent and antimicrobial, azelaic acid, 10, 15, 20%. Topical antibiotic, topical clindamycin, dolocin T, erythromycin, mupirocin, bactroban, sodium fusidic acid, less significant in the treatment. Systemic therapy, antibiotic, macrolides and tetracyclines, tetracycline, doxycycline, minocycline, blue-gray discoloration and drug-induced azithromycin. Rosacea, a controversial topic in dermatology largely because of its uncertain pathophysiology and clinical variation. Erythema of the central face that has persisted for months or more. Primary features: flushing, papules, pustules, and telangiectasis. Epidemiology: common in Caucasian population, fair-skinned individuals, women, men. Onset typically begins after age 30. Etiology and pathogenesis. 1. Vascular reactivity. Rosacea is induced by chronic repeated triggers of flushing exposure. They include 1. Hot or cold temperature, 2. Hot drinks, 3. Spicy foods, 4. Alcohol, 5. Certain cosmetics, 6. Medications, 7. Sunlight. Etiology and pathogenesis. 2. Dermal matrix degeneration and endothelial damage, inherent problems with vessels permeability, delayed clearance of inflammatory mediators and waste products, photo-damaged connective tissue, solar etiology and pathogenesis. The role of microbe-induced follicle-based inflammation, commensal organisms which reside in hair follicles and sebaceous glands may trigger folliculocentric, inflammatory papules. Demodex follicularum, mite, or associated B. In this image you can observe papulopustular rosacea. Rosacea variants. Granulomatous rosacea, rosacea variant, characterized by monomorphic yellow, brown or red papules/nodules located on the cheeks and periorificial skin. Granulomas on histology. The background facial skin is otherwise normal. Differentia. Treatment. Sunscreens. Avoidance of aggravating factors. Topical medications include metronidazole, sodium sulfacetamide and sulfur, azelaic acid, benzoyl peroxide, tretinoin, erythromycin and clindamycin. Oral medications include tetracyclines. Tetracyclines are the most commonly prescribed oral medications for the treatment of rosacea. They act by their anti-inflammatory effects. Erythromycin, for children with granulomatous perioral dermatitis, is sought.